Welcome. This presentation covers persistent postural-perceptual dizziness, commonly known as PPPD. We will explore the mechanisms behind the condition, the ENT perspective, and the multidisciplinary approach needed for effective management. Let's begin.
Vertigo refers to the illusion of self-motion. Either the sensation of spinning when the body is perfectly still, or a distorted sense of movement during normal head motion. It is a hallmark of vestibular dysfunction.
Dizziness, however, is different. It describes a disturbed sense of spatial orientation without the sensation of spinning. Patients often describe feeling off balance, foggy, or disconnected from their surroundings.
PPPD usually begins with a clear trigger: vestibular neuritis, Meniere's disease, vestibular migraine, or other acute or episodic vestibular disorders. Medical illness, neurological conditions, and significant psychological stress may also precipitate the syndrome. This early destabilization sets the stage for chronic symptoms.
During the acute phase, the brain shifts into a high-alert survival mode. It increases reliance on visual cues, tightens postural muscles, and becomes hypervigilant to prevent falls. For most people, this pattern resets, but for some, it does not.
In a subset of individuals, the brain does not switch back after recovery. Even after 90 days, the body continues operating in danger mode. It overuses visual information, underuses vestibular signals, locks the posture rigidly, and interprets normal movements as unsafe. This produces the persistent internal dizziness of PPPD.
Balance relies on three major pathways. The vestibulo-ocular reflex stabilizes gaze with remarkable speed. The vestibulo-spinal pathways maintain posture and equilibrium, and the cerebellar circuits fine-tune movement and coordination. In PPPD, the integration of these systems is disrupted.
When vestibular signals slow or become less precise, the brain turns to visual and proprioceptive inputs. But these signals are slower, creating a delay or lag. Patients perceive this mismatch as rocking, swaying, or floating, even when the body is completely still.
Four mechanisms contribute to the feeling of swaying: vestibular imbalance, visual dependency, inconsistent proprioception, and central processing variability. Any combination can create the characteristic internal motion sensation.
Balance depends on harmony between vision, proprioception, and the vestibular system. In PPPD, these systems no longer synchronize smoothly. As a result, patients struggle most in visually rich environments, such as supermarkets, busy streets, scrolling screens, or even while standing still. The brain becomes overwhelmed by conflicting signals.
Although PPPD is not a psychological disorder, anxiety plays a significant role in amplifying symptoms. Hypervigilance increases dizziness. Dizziness increases worry, and the cycle reinforces itself. Breaking this loop is key to treatment.
The core issue is functional. All tests may appear normal, yet the brain behaves as though stability is compromised. This is a disorder of central integration, not ongoing inner ear damage.
Patients often describe an internal sensation of movement: rocking, swaying, floating, or feeling on a boat. They may experience cognitive fog, derealization, and frustration because symptoms are invisible to others. Many feel misunderstood or dismissed.
ENT management focuses on reassurance, clear explanation of the condition, referral to vestibular rehabilitation, and engagement with neurology or psychiatry when needed. Follow-up helps patients regain confidence in movement.
Management of PPPD is inherently multidisciplinary. ENT specialists rule out peripheral disease, while physiotherapists, neurologists, psychologists, and rehabilitation teams provide coordinated care. This collaborative approach leads to the best outcomes.
Thank you for your attention. We welcome your questions and discussion. For further information, please visit mfcta.org.